In clinical documentation and coding, a single, absolute rule governs the entire medical record. Only the patient's provider has the authority to establish a diagnosis. In the context of ICD-10-CM guidelines, a provider is strictly defined as a physician or a qualified healthcare practitioner who is legally accountable for establishing the patient's diagnosis. But modern patient care doesn't happen in a vacuum. It relies on a sprawling network of auxiliary staff, nurses, dietitians, emergency medical technicians, all actively treating the patient and charting their findings. This creates an immediate friction point for medical coders. Auxiliary clinicians generate massive volumes of highly specific, vital clinical data, leaving coders to determine if any of that information can be legally extracted for a claim. The most common trap is autonomously generating diagnosis codes based entirely on the observations of these non-provider staff members. To resolve this, Guideline B.14 functions as a regulatory bridge, providing a specific framework of exceptions where auxiliary data can be captured without compromising the physician's accountability. Before you can extract a single metric, there is an absolute baseline prerequisite. The auxiliary clinician in question must be officially authorized to document their findings in the medical record. That authorization cannot be assumed. It must be explicitly established by internal facility policy and align directly with overarching regulatory guidelines. While medical teams rely on this constant stream of multidisciplinary data to treat the patient, coders must filter that same information through this specific legal lens. The exceptions granted under Guideline B.14 are not left to coder discretion. They belong to a rigidly defined list of specific clinical conditions. Look at this matrix mapping the 8 authorized exceptions. The first category covers physical metrics, body mass index, the depth of non-pressure ulcers, and pressure ulcer staging. These measurements are historically and practically delegated to nursing and dietary staff, who monitor the daily incremental changes in a patient's physical state, while the physician manages the broader care plan. The second category includes critical neurological and trauma scales. This allows coders to extract the coma scale, usually recorded by first responders, and the NIH stroke scale. The third category covers systemic or historical data points, social determinants of health, blood alcohol levels, under-immunization status, and laterality. Cautionary: this matrix is completely exhaustive. You cannot extrapolate these permissions to unlisted conditions or assume similar metrics are also exempt. The legality of using these specific metrics depends entirely on how they connect back to the attending physician's own findings. This brings us to the operational core of Guideline B.14, the tethering rule. Auxiliary data cannot spontaneously generate a diagnosis on its own. Its sole legal function is to add specificity to an existing diagnosis established by the provider. Let's look at a clinical example. A dietitian documents a patient's BMI as 32. You can code that BMI metric, provided the physician has formally charted an associated diagnosis, like obesity or overweight. But if the provider never explicitly writes obesity or overweight in their notes, the dietitian's BMI calculation becomes entirely uncodable. The exact same logic applies to nursing notes. If a wound care nurse documents a stage 3 pressure ulcer, that staging information is ready to be coded. However, that detailed stage is legally invalid unless the provider explicitly diagnosed the underlying presence of the pressure ulcer in the first place. Finally, consider emergency trauma. An EMT records precise coma scale metrics in the field. Those metrics provide vital specificity for the final claim, but they remain completely reliant on the physician documenting the overarching stroke diagnosis upon arrival. That is the essence of the tethering rule. The auxiliary clinicians supply the granular details, but the provider must permanently hold the foundational diagnostic anchor. Even when auxiliary data is properly tethered to a provider's diagnosis, certain delegated metrics are subject to heavy sequencing restrictions on the final patient claim. Specifically, body mass index, coma scale, the NIH stroke scale, blood alcohol level, social determinants of health, and under-immunization status. These specific codes carry a strict mandate. Assigning any of these listed codes as a principal diagnosis is an automatic compliance failure. They must be reported as secondary diagnoses only. Beyond sequencing rules, the multi-author reality of a medical record inevitably produces contradictory documentation. Consider this scenario. A wound care nurse charts a pressure ulcer as stage 3, but the physician charts the exact same ulcer as stage 2. When encountering this type of direct clinical contradiction, the coding protocol is absolute. You must query the provider for clarification. Defaulting to the highest severity, selecting the lowest severity, or attempting to make clinical assumptions on behalf of the staff is strictly forbidden. Adhering to constraints and resolving contradictions through queries ensures the final claim reflects a consensus of documented care, rather than a collection of conflicting data. To synthesize guideline B.14 into your workflow, we use the MJ-GEM, a simple logic equation. First, the provider establishes the diagnosis. This is their exclusive role and the anchor. Second, the authorized clinician supplies supporting data, adding specificity to reach a compliant code. You can operationalize this logic gate by applying a practical 4-step mental checklist to every piece of auxiliary data you encounter in a chart. Step 1. Verify the authorship. Ask yourself, who documented this detail and are they authorized to do so? Step 2. Confirm the anchor. Is there a foundational provider diagnosis clearly documented to tether this detail to? Step 3. Check the sequencing constraints. Does the resulting code fall under the secondary-only mandate, like a BMI or coma scale? Step 4. Scan for contradictions. Are there any conflicting notes between the provider and the auxiliary staff that require an immediate query? Failing to execute this logic gate in your daily practice carries severe professional stakes. Extracting unauthorized clinician data or violating secondary constraints leads directly to compliance issues, failed audits, and negative impacts on facility revenue. In every coding scenario, the final outcome rests on a single requirement: no provider diagnosis, no code.